Hey guys, Rav here to talk to you about knee injury mechanics. And for those of you that know me would know that this is one of my favorite things to talk about. I actually did my PhD focused on knee injury mechanics. Now you can see that it says ACL in brackets. Just so you know, ACL stands for anterior cruciate ligament. It's one of the key ligaments in your knee joint, and we're really going to be focusing on that particular ligament for the sake of this video series. Now, if you're watching this video and you're currently enrolled in EXSC 220, which is the undergraduate biomechanics unit at Australian Catholic University, got a few learning outcomes for you guys. The first is I want you guys to be able to identify the key components for understanding any particular injury. So this would be getting some sort of understanding of its etiology, its mechanisms, and its risk factors. So you need to know what all of those terms mean and how you might gather that data. I'd also want you guys to be able to identify and justify interventions that would potentially reduce the injury risk, and importantly be able to provide some sort of biomechanical theory or rationale where relevant to support these interventions, and then generally have an ability to apply evidence-based knowledge in a real-world situation. Now obviously those first three learning outcomes are relatively generic in terms of not really focusing on any particular injury, and that's a really important skill that I want you to be able to develop. But obviously with my final point, clearly we're going to focus on knees in this video series, so I want you guys to have an appreciation of how to apply these in knee injuries in particular. Now, obviously I could have picked any injury to focus on, so you might be asking, why are we focusing on knee injury as opposed to some sort of other injury? And I suppose there's a few ways that I could go about answering this question, but one thing to think about is that knee injuries are relatively common, and on top of that, they're quite traumatic. So to open up, I'll just give you guys some data from a fairly recent paper. Now I won't bother trying to pronounce the name of the lead author on this one, but essentially this is some data that has come out of Australia. So on the y-axis, we have the incidence of ACL injury, and that's expressed per 100,000 population. So you can just think of that as the rate of ACL injury. And then along the x-axis, we have the year. So on the left-hand side, we're starting with the year between 2000 and 2001. Then as we go towards the right, we eventually end up with the year between 2014 and 15. Now, when I show you the data, what you'll notice is a trend suggesting that ACL injury rates have actually been steadily increasing over time. So clearly, ACL injury is an increasing issue in Australia. Now, another really important thing to think about is that if you tear your ACL, you're going to be out for at least 9 months in most cases. And to be honest, for most people, they're probably out for about 12 months. So when you tear your ACL, it's quite a traumatic condition. So you might have to go through extensive rehabilitation, you might have to go through surgery, and obviously if you're an athlete, particularly an elite athlete, you can't play at that level whilst you're recovering from the injury. That's obviously going to be quite costly to the team. Now, it's not just costly if you're an elite athlete, even if you're just an everyday punter. Obviously, you might need to pay for extensive rehabilitation. You might not be able to work for a while. You might not be able to do your recreational sport. And you may also need to get surgery. And that's something else to think about with ACL injury. So here I've just got a really crude sort of model of the knee joint with just a couple of key muscle groups identified. So you can see the quadriceps towards the front of the knee, and then also the hamstrings at the back. Now here I have a relatively crude drawing or representation of the ACL in green. Now obviously the ACL is a ligament, and ligaments are important for maintaining stability at the particular joints that they cross. So if you rupture your ACL, one thing that you're going to notice is a clear reduction in the stability of the knee joint. So for some people, they will choose to go ahead and live their life without their ACL, but then they probably have to do some sort of rehabilitation to train muscles like the quadriceps and the hamstrings to stabilize that knee joint a little bit better. Now, that's not necessarily the most common outcome. The most common outcome tends to be a surgical intervention. Now, in a surgical intervention, what they do is they try and get some tissue and then use that to repair the ACL. And the two most common types of surgery that we tend to see are the patella ligament graft and the hamstring graft. So in a patella ligament graft, what they really do is they take a little bit of that patella ligament tissue and then they use that to repair the ACL. Another really common site is one of your hamstrings called the semitendinosus, and they take a little bit of that tendon and then they use that to repair the ACL. Now, it's not always just the semitendinosus by itself. Sometimes they take a little bit of your gracilis, and a gracilis is just another muscle in your thigh. They take a little bit of the gracilis tendon, they combine it with the semitendinosus, and then they use that to repair the ACL. So those are two of the most common types of surgical interventions that they tend to use. Now, if you tear your ACL, there will be some period of immobilization, so your muscles will tend to atrophy. So muscles like the quadriceps and the hamstrings, which you can see I've got in there, they will tend to atrophy and become weaker. Now, if you take a graft from the patella, generally what you'll see is the quadriceps will tend to atrophy a little bit more and become a little bit additionally weaker. Likewise, if you take a little bit of that semitendinosus graft, what you'll find is the semitendinosus over time will tend to atrophy, become weaker, and this tends to persist for years after the injury. Now, this is particularly important because if those muscles become weaker, their ability to stabilize the knee joint also becomes compromised. So what you'll learn later in this video series is that the hamstrings in particular are really important for maintaining integrity of that knee joint and also supporting the ACL. So if you take a semitendinosus graft and your hamstrings become weaker, potentially you might be at increased risk of ACL injury in the future. In addition to that, if your hamstrings are generally weaker, you might actually be at increased risk of just tearing your hamstrings. So clearly taking graft tissues isn't just a simple fix for everything. It does offer some enhanced knee joint stability compared to not having an ACL, but there are some consequences there as well. Now, what's particularly alarming is that whatever strategy you tend to pick, so whether you choose to live your life without your ACL or whether you get some sort of surgical intervention, over time we still tend to see some long-term persistent deficits and some dysfunction. And what I'm talking about here is the dysfunction that happens with the articular cartilage. Now, just as a quick refresher, articular cartilage is the cartilage that you find in between bones at their articulation sites. So at the knee joint, what I'm really talking about is the cartilage that lies between the femur and the patella, as well as between the femur and the tibia. Now, we need this cartilage because bone is actually quite an abrasive material. So if you have bone rubbing on bone, that can wear away at the tissue and cause some damage over time. So having articular cartilage actually reduces friction and helps to make sure those bones glide nice and smoothly. But basically what you see after ACL injury is a much greater prevalence of tibiofemoral and patellofemoral osteoarthritis. And osteoarthritis basically means that cartilage has started to wear away, and we might potentially even be getting bone-on-bone abrasion, which is quite painful and also very debilitating. So clearly, preventing ACL injuries in the first place might be particularly important, not just to avoid the deficits associated with the injury itself, but to avoid the long-term osteoarthritis-related complications later in life. So now that we know why we're going after knee injuries and ACL injuries, here's a quick refresher of your knee functional anatomy. So basically the knee joint is what's called a condyloid joint. And condyloid joints are distinctly different from a hinge joint because they're biaxial. Now, a hinge joint, if the knee was a hinge joint, that would mean it could only flex and extend. And this is something that a lot of people assume, but the reality is the knee joint is actually a biaxial joint. So it can not only flex and extend, but it can also internally and externally rotate. So it's actually got quite a bit of range of motion in terms of rotation, especially when the knee joint is flexed. Now, what I really want to draw your attention to in this slide is some of the key ligaments in the knee. So on that right-hand side, you can see a diagram of the knee joint, and I'm going to point out some of those key ligaments. Then on the left-hand side, I'm going to explain what each of those ligaments' main function is, either from a side-on view and also from a front-on view. So the first ligament I'll draw your attention to is the ACL, and the ACL stands for anterior cruciate ligament. Now, when you're trying to get your head around the function of a ligament, try to think about what movement it tends to restrict. So that's sort of how I'll explain how each ligament works. Basically, what the ACL does is it stops the tibia, it stops anterior tibial translation. In simple terms, what that means is that it stops the tibia, which is basically your shin bone, from moving forwards relative to your femur. And your femur is basically your thigh bone. Now, in addition to the ACL, we also have the PCL. Now, PCL stands for posterior cruciate ligament. Now, it basically does the opposite to the ACL. So it basically stops posterior tibial translation, which is basically the tibia moving backwards relative to the femur. We also have a couple of key ligaments on the sides of the knee joint. So on the inside of the knee joint, or the medial aspect, we have what's called the medial collateral ligament. So really important to recognize that the C stands for collateral now. We're not talking about cruciate ligaments anymore. Now this is found on the inside of the knee joint, and based on its location, it actually helps to prevent what's called valgus. Now, if you don't know what knee valgus is, you can look it up, but essentially what it means, just imagine the tibia rotating in the direction indicated by that pink arrow. Now, sometimes knee valgus is referred to as knee abduction, but I'm going to use the term valgus for the sake of this video. And then on the other side of the knee joint, we also have the lateral collateral ligament, which basically does the opposite. So it helps to prevent excessive varus. And again, if you look at the direction of that blue arrow, if you imagine the tibia rotating in that direction, that would be knee varus. Now, knee varus is sometimes referred to as knee adduction. That's A-double-D-duction. But again, for the sake of this video, I'm going to use the terminology knee valgus and knee varus. So if you don't know what any of those movements look like, so you can't understand what anterior tibial translation is or what knee valgus is based on my explanations, it's probably worth just Googling it or looking up on YouTube before you move on to the subsequent videos in this series.